Hello everyone, this is Dr. Anusha Karumuri, Interventional Pain Physician at Krishna Institute of Medical Sciences. Today, I want to give a highlights about what exactly is a pain and the origin of pain clinics. So, we are glad to talk about this with Dr. S. Manimala Madam. She is the Medical Director and Academics in charge in KIMS Hospital. Her experience is vast in all the fields of anesthesia, cardiac anesthesia, ICU, pain management, and she is awardee of Lifetime Achievement. Also possesses lot of national awards as a best teacher. We are very happy to introduce Madam here to give and explain about what exactly is the pain management. Hi Madam.
Hi, namaste to everybody. Yeah, let us talk something about pain, which is a universal problem which happens in day-to-day life and many times ignored.
What is pain, Madam?
Pain actually has been derived from the word piona in a Latin area, which means suffering.
Okay.
So when you have pain, you suffer a lot. Whether it is physical pain, mental pain, whichever pain is called suffering. So that is why it is important that we get rid of the suffering at the earliest so that it does not leave any bad marks like the post-traumatic stress disorders and things like that when you have pain.
Correct. And what exactly is the roots for the pain management, Madam? Where did it start actually?
Well, actually the pain management started, I think, with people who are in anesthesia.
Okay.
So till that time, if you all remember, even in way back in 1500 to 1700, it was called the Romantic era.
Okay.
They were, that is BC. I'm talking about much earlier.
Okay.
So and later on at this area. So what people have seen at that time was mostly, people who were, philanthropists and physiologists and many other artists, okay, and some sort of a psychological area where they were looking at the pain. And that is the time they were saying it is day-to-day occurrence. We have to find some methods by which we have to relieve pain. So that is one of the earliest methods was morphine from opium.
Yes.
And that was the first drug actually for pain. And it is Rovenstein, who is an anesthesiologist, who has started the pain clinic in way back in 1936 in somewhere in New York and those areas, because they are the people who have relieved pain. Anesthesia came and that relieved the pain for surgery, and such way surgery could be done.
Correct.
So even the pain at that time from William Thomas Green Morton, who has done the anesthesia, and later on the obstetric pain is a terrible thing which is borne by every woman who gives birth, and that was also done by many anesthesiologists. And it became popular because Queen Victoria was given pain relief for her birth of her child, 7th or 8th child, and then it became popular. Otherwise it used to people who were trying to do the pain management for obstetrics or childbirth. They were beaten up, like M.J. Simpson, who was there in obstetric anesthetist. He was beaten up by people who said no, they not relieve pain. So that used to be there. Once the Queen got it, then everybody said okay,
acceptance.
So that accepted. So the acceptance of pain relief came for every area, and that is how it has progressed further and further with anesthesiologists.
Very interesting to know about introduction of pain management. Madam, can you give your experience? And you have been into various fields in anesthesia, and as a pioneer, can you explain how difficult was the pain management and how did you start pain clinic?
Yeah, Actually, when I went to Nizam somewhere in the late 80s, there was nothing. Really, there was nothing. At that particular time, we have developed cardiac anesthesia already.
Okay.
And anesthetist being in the pain area, so you have to relieve pain. So what are the two main important thing is the sensation, and sensation like temperature, touch, and position. All these are the senses. We'll
Yes.
feel it in the day-to-day life. And the pain is another thing. So pain is felt, and it is sort of converted to feeling the pain. So that has to be nullified by us.
Yes.
So we are used to doing that. So when we do that, this pain slowly evolved as a specialty for us. And having the anesthesiologist knowing about the pain and treating the pain, we are fairly okay, and we started a pain clinic for chronic pain. Acute pain we have taken care in the OT and in the post-operative and all that. But chronic pain was the one which was really badly not treated at all. So why did it go to even chronic pain? Because when it was acute, it was not treated
Addressed
properly.
properly.
Yeah, addressed properly. So that is the reason you have to develop some pain clinics in the OP, so that people will be sent to you. So it is difficult in the beginning to cut into that area, come into OP as an anesthesiologist. So in those days, we used to have pain clinics in Ahmedabad. Yes, there was somebody was running, and they were trying to train people. Now we have
Courses.
certificate
Yes.
courses, and you are also got the one here. So that is important. So you train people who like to relieve pain,
Yes.
not stay only in OT. So that is the reason we have, because I was one of the senior most people, so I
Correct,
could
ma'am.
get the starting of these pain clinics, and we used to run it fairly well, and we trained two people, senior people, to take care of that.
Very nice to know, madam. Actually, I've been listening to a lot of patients who those days who had come and told that you have given a blind blocks.
Yes.
And now that there are a lot of advancements, like ultrasound machines are there and newer drugs are there, that was like a heroism I felt, because blind blocks are very, very difficult. It has little bit of skillful, it should be more. When compared to image guided, it is definitely a dynamic step, which I can say. Having said that, I want to ask you, madam, anesthesiologist, how do you think they are apt to take up as a pain management?
So why I say anesthesiologist is the best person who can manage the pain part, or you can be pain physicians. Now what is anesthesiologist really is, we call them perioperative physicians. Peri means what? Before the operation, during the operation, and in the post-operative, to relieve pain and suffering, and also the trauma of the surgery, right? Without that, you cannot operate. And they are also very apt with their blocks. We give spinals, we give blocks for the supraclavicular block for the shoulders, we give femoral blocks. There's so many things we give. So we are very, and not only physician, we are very good with our hands. So when you have got the brain and the hand working, who is a better person who has both these things to do the pain clinic? Yes, you can take others like psychiatry, neuro, suppose if there is any neuromodulation or something like that, you can take them as clinicians, as a multidisciplinary team, and call them when you require. But the basic personality has to be a perioperative physician, and also sometimes I'll also call perioperative surgical physician. Okay, that is, I just add that one, so that it is, that you have got very good hands to do those things.
Correct.
So I think who is better than that to manage pain clinics?
Yes, madam. I totally would like to give more and more our hard works towards all the aspects of pain. And as you said that we have a surgical knowledge as well as physician knowledge. It's a fast forwarding of BP, sugar and other vitals during the surgery. So, madam, there are a lot of various specialities after anesthesia. Pain management has become a subspecialty or a super specialty. So, any inputs for our generation, for next coming up candidates who would like to choose pain management as a career?
Yeah, see, every decade shows some changes, and then you will be taking up something better, something what you like. So it all depends upon what you're. So when we started, there was nothing much in cardiac, but we started cardiac anesthesia. Later on, we have started critical care. Now we have started emergency medicine as anesthesiologists. We have started most of them. I have started. So what is important? Pain also we started. So those who want to be very communicative and very have got a lot of interest in that particular area, I'm sure they will be taking up. Now you have got a certificate course from the Indian IAPA, so that they have got these certificate courses, so that people are coming up. Now we have got one fellow.
Yes.
So this is important. What they like, they will take, whether they want to do critical care, whether they want to do pain, whether they want to do regular anesthesia. Now even in anesthesia with the ultrasound, I think we are almost going to every small place and putting a needle and giving pain relief post-operatively. So that makes a lot of difference. And when you see the patient, I'm sure you see when they tell you, doctor, I think I had a wonderful time, I did not. I mean, you feel very happy.
Satisfied.
Many of them may not tell that to the anesthetist because they forget about them after they come out of anesthesia. They'll thank the surgeon and go. But here, they thank you and you feel more happy to do more things.
Yes, ma'am.
So I think it will be normal for people to take up. We don't have to go after them.
Yes, ma'am. As you said, relieving a pain is biggest satisfaction, I can say.
Yes.
Both acute and chronic. So, the last but not least, madam, you have been seeing lot of generations, how they are evolving in different fields. How do you think pain management has taken a next level?
Because now there are a lot of advances which have happened. As I said, ultrasound has made it a tremendously easier way. As you said, I remember a time when we used to do blind blocks.
Blind blocks.
And there was no place to give. So I started it in my own room. But I kept all the equipment where I can resuscitate people. Because as an anesthesiologist, we can resuscitate anybody. That is our greatest strength. So there was one lady, I was giving a trigeminal, suddenly she fell down. So then I had to put her on that bed and then resuscitated. And she came out, and after that I said, no, not here, let us go. So that is how the pain clinic for me started. So these are all things. Now you have radio frequency ablation, you have got x-rays, you have got C-arms, everything. So you can see and put your needle with ultrasound. So that is great.
Safetyness has increased, ma'am.
So as we, in everywhere, anesthesia are the people who started safety. So why some people are dying because of respiratory problems. It was much high in those days, in 50s and 60s. But now hardly any anesthetic deaths. That is because we have looked at the safety. Same way, all these help you in safety and you feel no tension when you do these things.
Yes,
I'm sure. Of course, till the patient becomes all right, you have, as a doctor, we will be worried about them. But as a compassionate doctor, trying to tell them, talking to them, all those things will, make it happy.
Any pain in the body, it travels from the site of injury to the brain via certain circuits, I can say. So, madam, what exactly are these pathways?
Yeah, pain pathways are not that complicated as compared to many other pathways. Now, suppose if there is a pain near the ankle, this particular, it is called a noxious stimulus. Suppose you hit your ankle, then there is something that will very quickly travel to the brain, which is called the sensory cortex. Okay, so by that time it is traveled, it has gone through a lot of areas, go up to the spinal cord and then go to the other side. It will go from one side to the other side, to the left side, and then it will travel up. and goes to the sensory cortex by spinothalamic, lateral spinothalamic tracts. Here, when the pain is there, there are very fine receptors, alpha receptors and then C receptor, like that. So those receptors get stimulated and send it to the central cortex, whatever. And from there, in another pathway, it comes down saying, okay, remove your leg. It all comes in a fraction of a second. So that is the pain pathway. And the person who has said about this is one of the, is not a doctor, but he is called, Descritus. And the diagram which they will depict also shows directly from how it is going so quickly by the pain pathway. That is the pain. It is felt and then it comes down what to do. So if we can manage the pain there directly over that place, or is it on the higher level, what has gone to there, and if you don't manage, then it will become psychological problem later on. So that post-traumatic stress disorder, which is usually, if you don't manage pains or psychological problems, is what patients will suffer from. So that is why whatever may be the smallest also, we have to try with the
aggressively
the drugs which are there, which is available, with the least amount of complicated drugs. And then we have to tell the patient very clearly that this is the complication which can have, look out for it. So
earlier the best.
Earlier the best.
So, madam, having said all these pain pathways, and now that we have certain kind of pharmacological things at each level, whether you take at the skin level or subcutaneous level, spinal level and brain level, all various pharmacological methods are there. And you have done many researches in pain management. Could you give a small insight about how exactly in the ICU the pain management is dealt? Because that is a very challenging aspect and you have done many researches in that. So
in the ICU, pain management is a little different in the sense, many times they are very critically ill. So we can't use all type of drugs, and combination of all the drugs, sometimes the blood pressure may not be okay. Sometimes the patient may be having a cardiac problem, sometimes patient having a respiratory problems or neurological problems, but he will be having some pain. So these are the various aspects depending upon, and sometimes we use the nerve block. Suppose if a patient comes with a hip injury and before he is taken to surgery, sometimes they have got a cardiac problem, they may be in the, so I give a femoral block so that the patient can move a little and not very worried about it. So like that, suppose if he has got a chest injury with rib fractures, so we give a block there so that it will be. So that is why I am saying anesthesiologists are, whether in the critical care or whether they are in the pain, they are easy for them because that is their routine thing.
Yes.
Other things like morphine and tramadol and dexmedetomidine which has come, which also reduces the way the delirium in patients in the ICU.
Correct.
So that is why I use a lot of dexmedetomidine, provided the patient is very stable in a very small dose.
Yes, ma'am.
So that will help.
True.
And we can use tramadol injections. I have done some studies and they proved to be quite okay. So once you're giving infusions, then you can give a smaller dose. So these are all that we can
multimodal way.
Multimodal.
Yes, ma'am, you're right. In ICU, we have to almost think about all the aspects.
Yes.
Cardiac, or whether it is rib fractures, or whether it is underlying renal factors, everything has to be considered to use a particular pain medications. And also, if there is not enough relieved, then the patient can remain in the ICU for a long time.
Okay.
Like in the rib fractures, they can go into the ventilator if their respiratory pattern is not good because of the pain. Thank you very much, madam. And as you were listening about how pain management advancements occurred and what are the roots of pain management. Today the safety levels have increased. Many people are still thinking about how these injections may have complications and all that. But taking the inputs of senior most anesthesiologists and the experience, we can happily say to most of the extent, these injections like take at epidural or nerve blocks have increased a lot of safetiness, and we can prevent major surgeries if there is a scope for only pain management and if there are no red flags for the surgical indications. Thank you lot. Have a good day.